Okay, that's good. Everyone satisfied? All are you happy? No question. All the guidelines are clear. That's good. Okay, so Sadia, this is the case. Okay, and this I'm not sure. Do you can see or there is some delay? Can you see my? Can you see?
I can see the clocks on it, but there
So the
was a
case
case.
will come now. Yeah.
Yeah.
And just anyone want to join, if someone can volunteer and just admit them, there will be here like sign for admission. Anyone just to press enter or admit. Okay. But I'm not expecting a lot of people to admit, to come today because we have been not doing this session unfortunately for a while now. Okay, and we just resume this week. Okay, so yeah, let's do you do
Discuss.
you so usually I'm doing do you want it like the exam, 3 minutes and directly to go to the 12 minutes, or you want to discuss it in between?
Oh no, no, like exam only. So
Okay, that's
yeah,
fine.
yeah.
When is your exam? Next month?
June,
June, okay,
June.
there is
Yeah.
time. Okay, that's good. So that's it's a two pages. So this is the first page and this is the second page. Okay, so when you reach down, okay, when finish the reading, tell me just to scroll up. We'll scroll down according your wishes. Okay, I will start the timer. The 3 minutes timer is yours now. Okay, shall I start? Okay, the 3 minutes is yours. Do you want me to scroll
Can you?
down?
Yeah, can you
Scroll
scroll down?
down.
Yeah.
I finished it.
Could you scroll up a little bit?
Sure.
Let go. Hi, I'm Sadia, one of the doctors at the practice. Is it Olivia Green I'm speaking to?
Oh yeah, doctor. I'm Olivia's Green.
Hi, Olivia. I can see you come in to discuss your pain relief. Is that right?
Oh yeah, doctor. To be honest, the cocodamol has been for ages on my, on my repeat list, and I'm not
Okay.
using it that often. But
Mm-hmm.
sometimes I truly need it, and then
Mm,
I just call and I try to order through my NHS app, but then they tell me you cannot. You need to
mm.
discuss that with the doctors. So I'm not sure, and even if someone would have changed my medication, why no one told me that, doctor?
I'm sorry that you felt that way. It's just because some of the medication have some side effects, like a long-term side effects, and we would like to know exactly what you're using it for. Is it really helping you or not? So that's the reason we have this medication reviews. But I mean, I'm glad you're here today, and we can discuss how you said you've been using it for quite some ages. So how long would you say?
Well, I think, well, we will say 2 years probably.
2 years, and is it for what reason? Is it for your tummy pain or?
Oh yeah, doctor. So I have this, ongoing tummy pain, and it's no sense to be honest. And even
Mm,
the gastro, I think, consultant in the hospital did a lot of
mm,
investigation, and they didn't, they told me it
mm.
might be irritable bowel, but
Oh, okay.
I'm not sure about that. But and he said we need to give painkiller for that.
And
So
did they
that.
did
Mhm.
yeah, go ahead.
Yeah, so that's why I'm using it. And the issue, if I didn't, nip it in the bud, the pain, and I will keep
Hmm.
vomiting for a few days, and really,
Mm-hmm.
really, that's will be disaster for me. Sometimes I need
Oh
to go to
God.
the hospital to give me fluids to stop the vomiting.
Oh God, I'm sorry to hear that. And how long has all this been going on for?
Yeah, at the same time, around 2 years now, doctor.
2 years now. Okay. And how often are you having these cycles of vomiting with the tummy pain?
Well, I can't, there is no specific time. I can't predict it. But once
Mm,
I know, what I know is
mm,
when there is pain and the
mm,
nausea started, I need to stop
mm,
that from progressing to the
mm-hmm,
persistent pain and the
mm-hmm.
cycles and cycles of
Yeah,
vomiting.
yeah. And is there any specific triggers you have noticed with this
No,
tummy
no,
pain
not really.
and no, and so some specific questions regarding your tummy pain. Where exactly do you feel the tummy pain?
Well, all over my tummy.
All over the tummy. And is it? I mean, when you have these cycles of vomiting, how long do they last for?
Sometimes we'll stay 2 days, 3 days. Maximum will stay a week.
And when was the last time you went to the emergency for some IV fluids?
Well, I think
Some
1 year
fluids.
ago, because once I control the beginning of the pain, that
Mm-hmm.
will prevent the things from progressing, and that's why really I need the cocodamol, doctor.
Yeah, definitely. I mean, we can have a look into it. And how? I mean, when you do take the codamol, how do you feel after that? The
Well,
pain
not
goes away
no no
immediately, or
no no no,
no?
doctor. I need to take some, and then
Mm,
that will improve by time. Sometimes it will not work even, doctor. Sometimes it will not
mm,
work,
mm-hmm,
but usually it will.
mm-hmm. And with these vomiting, have you ever felt dizzy also?
Dizzy? No.
Yeah, no. I mean, have you ever felt sweating?
Sweating? Not really. No.
No, really. Okay. And you're you're weeing okay? Any problems passing wee?
Yeah, yeah. I'm being
And
fine.
okay. And any problems with with your poo and your bowel? Any problems passing poo?
No, I'm quite regular,
No.
doctor. Yeah.
Mm-hmm. And
But
any weight change? Yeah, go ahead. Go ahead.
yeah, it's just yeah. Thank you for asking about my weight. Yeah, I'm losing weight, but I know that I'm losing weight
Mm,
because I'm not able to eat. When the pain come, I become apprehensive. I can't go for
mm,
eating. I'm worried, severely worried to go to eat. Otherwise, I will start to vomit, and that's why I
mm.
think I lost weight.
Yeah, and how much weight would you say you've lost?
I think the nurse did weigh me last week or something. I lost over a year, like 10 kilos.
10 kilos in 1 year. Huh?
Yeah, over the
Mm-hmm.
year.
And tell me a little bit about your diet. I mean, when you are not having these sickness episodes, how are you having your? I mean, how is your diet?
My diet generally is fine, but the issue is
Mm,
when the pain come, doctor. As I told you,
mm,
I'm trying to avoid. I'm always trying to eat healthy
mm,
fruit and vegetables,
mm.
avoiding fatty meals, or even
Mm.
avoiding salt in my meals, just to,
Oh,
because of my blood pressure. I
mm.
don't want my blood pressure to raise
Blood
up,
pressure to
because
go up.
sometimes when
Mm.
the vomiting come, my blood pressure would just shoot once.
Oh,
In the hospital,
oh.
they find it around 180 over 100 or something.
That's quite high, isn't it? Yeah. And with these, I mean, you've not noticed any flushing or any other symptoms with the vomiting,
Flushing?
like
What you
flushing
mean?
of the face, flushing on the
Uh-huh.
face, flushing of the
Okay,
face.
no, no, no.
No. And like before, in 1 month, how many times would you say you were having these episodes of vomiting and tummy pain?
Well, in a month time, sometimes will come once, sometimes will come twice.
Twice.
Sometimes I
Okay,
will have
fine.
it, every week.
Mm-hmm. Okay, fine. And any headaches?
And no, just if if I vomit a lot,
Mm.
then I would have some headaches.
Mm-hmm. So, and obviously, you are quite concerned regarding this pain and this vomiting, and this been going on for quite some time, and you've not able to find any triggers to it. From what I could hear today, I mean, this is causing quite a lot of distress. We've tried to quite a lot of things actually. We've tried to modify your diet, and I think the co-codamol helps, but not all the time. Is that right to say?
Yep.
Yeah, and I mean, you kept a diary or something, anything which triggers any stress, any anxiety, or anything like that?
No, to be honest, doctor,
No.
I'm not a stressful person. I don't
Hmm.
have a
Hmm.
stress in my life, to be honest.
Mm, hmm.
Yeah.
Sorry, I didn't
Mhm.
ask much. Many of your little bit of lifestyle, like smoking and alcohol can also affect your, like be play a part in causing these symptoms. Do you smoke or drink?
You mean normal cigarette? No, I'm not.
Yeah.
Yeah, I do vape.
Mm,
Alcohol. Occasionally I will drink. Once in the blue
mm,
moon, maybe.
okay. I mean, with these episodes of you having these episodic vomiting, like with episodes of vomiting and with this pain, and so, I mean, quite, it doesn't sound like very typical of IBS. Sorry, I didn't ask you. Do you feel any bloating in your tummy?
No, not really.
No, no. So it doesn't sound very typical of IBS symptoms, which the gastroenterologist said it is. I was thinking, of maybe if I can see you up in the clinic, like face to face, and maybe do a weigh you and actually examine your tummy.
Sure, yeah, yeah. But what are
Yeah.
you thinking about, doctor? Well, it will be
So,
useful if you could
yeah,
reach what is the cause of that. I don't like medicine. I won't take the medicine, but
yeah, I agree with
just
that.
I
Yeah.
need it, doctor.
Mm. So I think in your case, I mean, I think it may be. It sounds more like cyclical vomiting syndrome. I don't know if you've heard about it.
No, what is that?
No. So this is a condition actually. So it comes with bouts of vomiting, and you have tummy pain, and then it goes away by itself. So in so where there are episodes of vomiting, and then
Mm-hmm.
they last for a couple of days or few weeks, and then go by itself, and then
Mm-hmm.
you do experience some weight loss in like obviously because you're not been eating, and with these episodes of vomiting also ongoing.
Mm-hmm.
uh, so I would advise to keep a food diary actually. I'll and also to see if there is anything which any sleep deprivation or anything at all which can trigger this. And in the meantime, I would advise you to come and see me in the clinic. And so there are treatments which we can give you actually to prevent it. But I think you do need to be seen by the dietitian.
Oh yeah, they referred me to the dietitian doctor when they
Oh, so
diagnosed me
you were
with the
seen by the
query. Yeah, and he
okay.
just told me about the food map and Mediterranean diet
What ma'am?
and yeah, and
Yeah.
all of these things, and I did
Hmm.
apply it. Nothing is helping, but I
Hmm.
did
Hmm.
notice something that usually is helping me, but I'm not sure
Hmm.
is I'm imagining doctor or not.
What
Sometimes hot showers will help me.
hot showers?
Hmm.
Yeah. Okay. Okay. And any alcohol that helps you also, or
No,
no?
alcohol is not
No, no.
helping. I'm just wondering, doctor, what is this cyclical vomiting? What is causing it?
So sometimes, I mean, there is some, and there are if there are some triggers. sometimes, like certain food, stress, or sleep deprivation,
Mm,
or, like
no,
dehydration? No, none of that.
no,
So have you noticed any night sweats?
no, no night sweats at
No
all.
night sweats. It's just when you have a hot shower, you have, I mean,
Yeah,
that helps with this.
with the pain, especially with the pain.
Mm-hmm. So yeah, I mean, yeah, and so it's best if I do examine you actually in the clinic, check your tummy, and
Are
see
you
you
looking
face to
for
face.
something? Are you looking for something specifically, doctor, in your examination?
Just
I
to rule out
mean, I
if there
mean,
aren't any lumps or bumps in your tummy or anything of that sort. Have you felt anything?
no, doctor, because most of them,
Hmm.
I was examined by hundred of doctors, and lastly,
Hmm.
they make a camera scan for me, this camera tests, and then they
Hmm.
make a jelly scan as well, and
Hmm.
all was completely fine, to be honest.
Hmm.
Yeah.
Okay. Yeah.
Uh,
Yeah.
yeah, doctor,
Yeah.
I noticed something else, but don't tell me off to be honest, please, doctor. I noticed that a joint will help me.
Sorry, which one? Joint. The
Joint, yeah.
the cocaine. Is that what you're saying?
No, no, not cocaine, not a line. A joint is cannabis. I do
Cannabis.
smoke
Oh, okay,
cannabis. Yeah,
cannabis. Okay,
yeah,
cannabis. Huh?
I do smoke
So,
cannabis. Yeah,
so, and okay,
it's really
okay.
it's very
Hmm.
perfect. Once I smoke it,
Hmm.
everything gone.
And how long have you been smoking for?
Oh, quite a few years, maybe 3, 4 years now, but not much. Maybe
Okay.
in a week I will, over the weekend I will just smoke, a joint or
Hmm.
something with my boyfriend.
Hmm. So sometimes you can have some side effects actually. Been using it for quite some time. They can also be cause of these symptoms.
Okay.
Okay.
You want to continue?
Uh,
Did you get it?
uh,
You want to continue? You can, but just you need to know that after that, anything you will
yeah,
say after is not counted. But if
it's
you
not
want to
counted.
continue, yeah,
Yeah.
you can
No,
continue. Would you
that's
like?
fine. I leave. Yeah, no, that's fine. I leave it as
So,
so.
okay, so let's discuss, okay? And so, what you think?
So actually, I didn't ask about recreational drugs. So it was just
Yeah,
smoking and
yeah,
alcohol. I should have asked
mm,
about
yeah,
recreational drugs. I think
yeah.
cannabis can be a cause of abdominal pain and vomiting also.
Yeah.
So
Do you know
use and
what is the
abuse also.
syndrome? You know what is the syndrome name?
No,
Yeah, it's called
what is it called?
cannabinoid hyperemesis syndrome. It's common. It's
Okay.
very common, but unfortunately not all people have awareness about it. So and that's why it's
Mm-hmm.
missed, but it's very
Mm.
common.
Okay.
And if you start to track it in your practice, you will find it. You will find it very
Mm.
common, very very common. Okay,
Mm.
just the difference between the joint and a line. A line for heroin, okay, a line.
Okay.
Because it's
Liner.
sniffing, so they will put a line and
Yeah.
sniff it.
Mm.
Okay, and a joint is a smoking. Smoking cannabis. That's called a
Joint.
joint.
Okay.
Yeah.
Fine.
Okay, so
Yeah.
if yeah, it's good to know the terminology because that's mean that you have seen a lot of patients. So
Yeah.
that's only the reflection.
Yeah.
So would you do anything different? Would you do anything different if you have the case again?
Yeah, I would definitely refer her to alcohol and drug services. I mean,
No,
obviously
no,
bring her
not in
in,
the
ask
management.
her.
Not in
Oh,
management. I
sorry, in
mean,
the
in
in the
general,
data
yeah, let's
gathering.
take it step by step. In the data gathering, would you do something different? And then I will tell you what you could improve.
So obviously, the patient has been having cannabis for quite some time. Um, any other alcohol? So obviously, any other recreational drugs?
Okay,
Um,
yeah, that's valid. Valid. Any other
yeah.
recreational drugs? Do you know why? You need to ask about other recreational drugs. It's something I said I mentioned in the last video that I did from couple of days about bloody diarrhea. Also can be related to drug abuse. So why it's important in patient coming with tummy pain to ask about drug abuse.
Mm,
Beside the cannabinoid hyperemesis syndrome. So what else can drug abuse cause?
mm.
Which I just met, I think, from 2 or 3 2 days. I just met,
Mm.
some. I met it not in the acute phase. I met the patient in the chronic phase. I mean, in the resolution phase, and then we discuss, the drawbacks and what else can. And the patient can come with severe tummy pain, acute abdomen, and he need to be admitted to the hospital for probably operation or doing,
Okay, internal
intervention.
bleeding, like a internal bleeding of ulcer, like gastric ulcer or
Yeah, that a gastric
complication.
ulcer can happen. It can
Yeah,
happen even from
perforation and
alcohol. No, but there is
ischemic
something.
ischemic
No.
colitis,
Yes,
like
why? Why?
mesenteric, yeah,
Yeah, yeah, why? Why?
cocaine vasoconstriction.
This is one. Okay, cocaine can cause vasoconstriction, also can cause hypertension.
Hmm.
Something else, you can inject it and can cause problems. So
Hmm.
any injectable drug, like even
Ambulance.
yeah, yeah, air ambulance and other, yeah,
Hmm.
that's one of these. But uh,
hepatitis,
yeah, hepatitis, but
hepatitis.
yeah, hepatitis will be a complication, but it won't cause an acute abdomen. So if you have a patient that is injectable, injecting drugs, okay,
D.
um, they can have damage to their, infective endocarditis, isn't it? That's one of
Hmm.
the complications.
Hmm.
Sometimes can be subacute. So even the patient can present without symptoms, and then with vegetation will happen on the valve. And then after that, this vegetation can go to the intestine and called ischemic
Ambulance,
mesenteric
yeah,
colitis. Yeah,
yeah,
okay.
colitis, yeah,
So
I
be
got that.
aware about that. So always try to relate the drug abuse to patient with abdominal pain.
Hmm.
Don't ignore it.
Hmm.
Okay, don't
Hmm.
ignore. What else? What else? Oh, thank you for the doctor who participates. Who participate? Who did say hepatitis C? The doctor's name? You just because I'm not familiar
آه،
by the voice.
نسيبة سعد.
Nusaiba. Okay, Doctor Nusaiba. Yeah, thank you for participating, Nusaiba. Okay. What else you can do different?
Hmm. So ask the patient how they're using the intake, how they're using, and what their thoughts are on it, and I mean how long for what. I mean, like, is it like habitual or is
Ye-
it more like
Yeah, that can be.
addiction, or
Yeah,
yeah, with it
yeah, that can be.
the
But
dose of it, yeah, how much they're using,
yeah,
I mean
yeah,
the mode of
that,
it, and uh, have they changed anything different, injecting or like sniffing, and
mm,
so anybody else is there or with them using it, any other mental health issues, any other
okay.
depression,
So.
mood, anxiety,
Mhm.
um, and
No, the
then
most important why he is using the
yeah.
the drug of misuse, because in the
Hmm.
treatment you need to address that, because treatment
Hmm.
of the symptoms is stopping the drug, and then you will not
Hmm.
be able to treat him unless you
Hmm.
know the root cause analysis. Not all the people are drug addicts because they want the drug. A lot of people are using drugs to sleep because they have an anxiety, especially the cannabis. Cannabis now you can buy it over the counter. You can buy cannabinoids over the counter. So people are using it for treatment on anxiety. And by the way, cannabinoids that is sold over the counter have the same side effect of the cannabis in terms of cannabinoid hyperemesis syndrome. So even the medicated cannabis can cause that. But but in your structure, what you can change with, because that's important in the differential diagnosis of the tummy pain. Because to be honest, I felt that there is some misfit of the structures of your
Hmm.
structure. So in your differential, so what you could improve.
So basically, the site of the where the site was, and the onset duration,
Yeah.
and yeah, yeah, and then any associated factors, anything aggravating, relieving factors, and anything. So that was for the abdominal pain, and then
Mhm,
vomiting was also any blood in vomiting or any other symptoms,
mhm.
any other
Red flags,
GI
yeah, the red
symptoms,
flags, you
red
are right.
flags. Yeah,
The red flags, I
yeah.
didn't hear it except about, but I think that was because maybe the cases are challenging, so you didn't say your red flags. It's only what you said about, it's only the unintentional weight loss. But what about the other red flags? Although, the chronicity of the symptoms can just trump that there is maybe something sinister happening. Because if she is
Hmm.
having these symptoms for 2 years and then the gastroenterologist saw her, and and he have no comment in it, and he did a lot of investigation, and all are normal. That might be considered as a safety, a safety point for you, that there is nothing sinister maybe going on the background.
Hmm.
But in general, in female patient coming with tummy pain, because this is a female, yeah, Olivia is a female, so what you need, you must ask, which I didn't
Pregnancy test.
hear.
Yeah.
Well,
Pregnant.
pregnancy and the gynecological
Yeah.
history. What about the period? Okay, but maybe you have
Yeah.
endometriosis, isn't it? How the
Yep.
period? Maybe endometriosis and causing these hair symptoms, isn't it?
Mm.
Yeah, well,
Yep.
endometriosis is very tricky one, very tricky
Mm.
to diagnose, and can cause massive, GI symptoms, GIT symptoms.
Mm.
So
Mm.
endometriosis can cause infiltration to the intestinal wall, and even cause, blood in the poo. Okay, patient can
Mm.
present with hematochezia or melena because of the endometriosis. So always in a
Mm.
female patient, be aware about endometriosis as a differential diagnosis of your tummy, if the tummy pain, okay, or the
Mm.
abdominal pain. What else you might improve in your structure? Because there was some critical things. So one of the things we said, drugs of misuse. The other thing,
Mm.
what about the ice? I didn't hear the ice at all, isn't it?
Yeah.
What was her
Yep.
idea and concern and expectation? Yeah, she came mainly because she wants the cocodamol.
Mm.
Okay, and then the cocodamol was just a red herring, and actually you need
Mm.
to start to ask about if she is addicted to cocodamol itself. Codeine is causing
Mm.
addiction, isn't it? So
Mm.
just don't forget that. You need to ask her, if you didn't take the pain, do you have any back pain? Do you have any withdrawal symptoms of the codeine? So that's an important bit also. Okay,
Mm.
you shouldn't forget it, because codeine is very common drug that patient can be addicted to it, and
Mm.
mostly we are the mistaken in that, because we are just writing the medication without following it up. Okay, so let's take what you did. A lot of things you did good. Okay, you did introduce yourself. Okay, you did confirm the patient name. You did use the pre-existing information. Okay, in your structure, yeah, you did ask a little bit of, data gathering was there, but I couldn't understand a lot of differential. So when you are doing your data gathering, you need to put a differential diagnosis so you can go through your questioning. I did maybe get from your question that you was looking for bowel changes. Yeah, so you was thinking about GIT,
Mm.
and and you ask about urinary changing, water work symptoms, it changes. But then don't forget, the gynecological issues, and then metabolic issues can cause tummy pain as well. Okay, and anything in the thoraco-abdominal area can cause a pain. So you need to ask about
Mm.
heart racing, chest pain,
Mm.
coughing, travel, and TB. Okay, because TB also can cause chronic tummy pain, TB, mesenteric adenitis. That's one of the
Mm.
things. So that should be in your differential. And based on the fact that the patient is 42, she's hypertensive, that can trigger something. What can trigger for you? What usually when
Um.
the patient is 40, what we are doing? We are inviting them for healthy check. When what we are checking, we're checking weight, blood pressure, and sugar. Yeah, diabetes. Yeah. So
Yeah.
diabetic autonomic neuropathy, and gastroparesis can present like that as well. So that's one of your
Mm.
differential, and then that you need to add it in your investigation, your management
Mm.
plan, which will come in a bit in it. Okay. So that's what I can, maybe you need just to improve, and please don't, not asking the ice is critical in that exam,
Mm.
because your management plan is based on the ice, isn't it? You will need the
Mm.
ice, so you will build your management plan on the ice and address the patient concern and expectation. Asking about ice alone will not guarantee to you a good mark. Okay, a good mark using the ice in your management plan. Okay.
Mm. Yeah.
Yep. So coming to the management, you did reach the management in 4 minutes. I do appreciate that is a challenging case, and that's why maybe you was late. But then in the beginning of the management, is anyone wants to add anything before going to the management, doctors? Anyone wants to say anything? Want to participate in anything? No? There's only Dr. Nusaiba who would participate. No one want to participate? Anyone have question until now, or you are fine, doctors, with the... No? Okay. Okay, so coming to the management plan. So management plan, usually we said management plan is better to be started at 6 minutes, okay? 5 minute 30 is the maximum. And then you need, you know, in such case, you need to have some differential. You need to have a diagnosis for the patient, at least, or differential diagnosis, okay? Because this is a case of undifferentiated illness. So you need to have some diagnosis for the patient or differential diagnosis. Okay, before inviting him, or while inviting him to the face to face. Yeah, I want you to come for face to face, but saying I want to come for face to face alone is not enough for you to gain a mark, isn't it? You need to know why. A patient need to know why. Well, I want you to come in. I need to face, to feel your tummy and make sure there is no lumps or bumps. Perhaps I want to do, vaginal examination, to see if there is any problem with your vagina, or if she told you that I have bleeding or something. Yeah. So you need to nominate why you want her to come in. Okay, and on such patient, when you are examining her tummy, don't forget to examine her supraclavicular lymph node, isn't it? So that's my advice. If any patient have chronic symptoms and you are worried about cancers, don't forget to examine the supraclavicular lymph node, especially the left supraclavicular lymph node. Okay, for Virchow lymphadenopathy, which is the first lymph node will have metastasis if you have a gastric cancer. You know that, yeah?
Mm.
Okay.
Virtuous node.
Verkow. Yeah, Verkow.
Yeah.
Yeah. Yeah. Okay. And then yeah, you will come. Well, I think, yeah, you did say, I think it's cyclical vomiting. By the way, cyclical vomiting is one of the part of the syndrome, because when we see the PowerPoint, there is something called non-organic nausea and vomiting syndromes. Okay, and cyclical vomiting is one of them. Cannabinoid hyperemesis syndrome is one of them. Okay, and the other one is the chronic nausea and vomiting, non-specific chronic nausea and vomiting is one of them. So you was nearly there, okay, but a simple questioning regarding the drug of misuse was here crucial in the diagnosis, to be honest, okay.
Mm.
Food diary, yeah, sleep deprivation, I'm with you, okay, yeah, that's fine, because what you was thinking of, was thinking of migraine. Yeah, abdominal migraine is common in pediatric cases. Okay, and people with, in adults is not that common. Okay, it's not absolutely not, will not come to, will not appear in adults, but it's not that common. Okay, this is one. The opposite can happen. So if you have a child, which there is a reported cases, if you have a child coming with abdominal migraine, okay, don't forget to ask if the parents are smoking cannabis. Okay, because actually the patient can have cannabinoid hyperemesis syndrome with the passive smoking, and then that will need you to trigger safeguarding needs for that child. Okay, so also that's something you need to put it in definition when you meet a child with probable abdominal migraine. Okay. And if the patient is pregnant, then you need to put a differential of hyperemesis gravidarum. Okay, so patient coming with persistent vomiting, you need to put one of your, and she's pregnant, so hyperemesis gravidarum or cannabinoid hyperemesis syndrome, especially if she have, a history of cannabis misuse. Okay, is that clear?
Gotta keep
Yeah.
It's,
going.
what you will
Last
add then,
30. I'll finish
would you
this.
like to add some blood test or some investigation for her?
Yeah. Maybe use and ease, full blood
Okay,
count, liver
yeah.
function test, and
which was
Sexual
done.
anti-inflammatory markets. Yeah,
Yeah,
actually,
which
this
was done.
is
So what?
done.
Well, yeah. So again, the way you are thinking about the case as a missing story. Okay. So there is a
Mm,
story, and there is missing bits on it. Don't repeat what is already there, but add on
mm.
what is missed. Okay. So because if you repeat what is already there, that is misuse of resources. Okay. And you will make more financial stretch to the NHS. We don't need that. So what do you think? What is missed in her medication that in her investigation that you need to add?
If you can just scroll down,
Yeah,
I
is
think,
there? I'll bring it.
yeah. Did they do the HbA1c for her? I mean,
No, that's
no,
right.
yeah.
Okay, and what else?
So they've done the celiac screening fit test.
Uh, I will not say wrong, but that's fine because although she doesn't have any change in the bowel habit, yeah, and she doesn't have
Mm,
bloating, but I will not say it's fine. If I am in your place, I will do it to be honest, just to be in the
mm.
safe side. I don't want to miss anything, and then I will regret that I didn't fit. That's fine. I will do it.
And fecal
What else?
calprotectin, if she's had fecal calprotectin, I don't know.
There is no signs of inflammation.
And
It's very,
no,
yeah, and there is
is
no
a young
blood in the
lady with,
stool. Yeah,
yeah,
it's very difficult to have IBD without, without
diarrhea
constitutional
and bloody
symptom.
diarrhea.
Yeah, yeah,
Yeah.
yeah. It's very difficult.
Um,
She's hypertensive. What she should have
ECG,
done?
ECG, ECG should be
Usually
there.
ECG will do it in the diagnosis, but what about the follow-up? What you should do yearly, and they didn't do.
Urinary ACR.
Exactly. So don't forget
Mm,
any patient having hypertension, patient having diabetes, patient having CKD, bloods plus urine. Okay, urine, you want to do urine depth, see if there is hematuria, which is a marker of kidney problems. Okay, marker of kidney injuries. And the other thing, ACR, because again, it's a marker of kidney injury. In that specific patient, also, what you will look at in the urine dip, other than the microscopic hematuria.
proteinuria, or
Proteinuria, I will not. If it's there, I will not be worried from it. You know why? Because with the persistent vomiting, you will leak some protein. What you need to look at to make sure that the patient, you know, is safe to be managed in the community. Doesn't
ketones,
need exactly
ketone.
ketonemia. Yeah, ketonemia. So ketones is
Mm,
important in this case. Okay, because ketones is a reflection of the hydration status of the patient. Okay. Okay, don't. It's not only DKA. Okay, I know. DKA in the old ages. We used to use urinary ketone. Now it's not. It's not advisable. Okay, because it's misleading. We are using ketone in bloods. Okay, but in old ages we used to do ketones in urine, or in pediatric also ketones in urine can be quite significant for probable DKA. Okay, but actually we use the ketone in urine to assess the hydration status of the patient. If there is a lot of ketones, mean that the patient is dehydrated, and then you might
mm,
consider referring her for rehydration in the hospital.
mm.
So what about then treatment then in this case? What you will go for?
So basically, so I'm trying to find out the reason behind her having being on
Yep.
cannabis
Yes.
to, yeah, treat that if she has any mental health and underlying reason associated with this, maybe counseling, or depending on what other psychiatric problem, if she is
Yes.
suffering with any so treat that. So I think with cannabis dependence, I think it would be mostly managing psychosocial, and then if she agrees with that, maybe do like the CBTs are there, and then drugs and
Yes.
alcohol
Yeah. And
services. Yeah.
yeah, exactly. Drug misuse and alcohol
Hmm.
services. You need to refer her
Hmm.
to there, and they will deal with her, and they will be able to treat her very
Hmm.
sensitively. Okay, because and you need to tell her what she can expect. Okay, it will not be an easy journey. She need to do cold turkey stopping of cannabis, cold turkey, and stopping the cannabis cold turkey will make her having more hyperemesis. Okay, and that and until around 4 weeks. For it will take about 4 weeks. Once the withdrawal symptoms gone, okay, and she's off cannabis for 4 weeks, the is finished. The syndrome will be aborted. Okay, and I will explain that's why, because it's related to some receptors in the brain and the gut that are down regulated by the cannabis use, and once you stop it, it will be upgraded again, especially in the CTZ center. So the central vomiting center, okay, receptors. um, so if she have what do you think, how we can then try to help her with her tummy pain during the withdrawal symptoms? How the tummy
So,
pain and the vomiting?
uh, so like give her some obviously monitoring.
Antiemetic,
Yeah.
antiemetic, is it? So
Mm,
what do you think antiemetic will work?
cyclizine.
Nah, very weak to work.
No.
Yeah, cyclizine very weak, and it's acting peripherally.
Metoclopramide.
Yeah,
Metoclopramide. Meto.
metoclopramide will help little bit, but not much. So because the receptor is central and peripheral, so
On
you need to act
densitron.
exactly. You need to act on the central receptors, on dancitron and something else. Something else. I'm sure you use it many times in the practice. Something else. What you are using? What are you using in the vertigo? What are you using on?
Prochlorperazine.
Yes, Timetil. Yeah,
Stimatil,
prochlorperazine.
yeah.
Yeah, that will help. Another simple thing that also can help. That will help with the vomiting. What will help with the pain?
Like
If you have patient having neuropathic pain and you
non-steroidal.
no, that may be worse the things. If you have
Neuropathy.
patient,
Amitriptyline.
I will,
Amitriptyline.
some yeah, it can help. It can help, but I will not go for it. It can help, but because I might induce another problems.
Mm.
What else? It's difficult to get it, but I will explain the science behind it. Hmm.
Mm.
If you have chronic
There's
osteoarthritis, what you are giving them?
uh,
Something that whenever you order it, it will never come. The patient should order it over Amazon or eBay. Hmm. What do you think?
I have no idea.
Capsaicin cream.
Uh,
Yeah,
have
can
they
you
not
imagine?
stopped that? Have they not
Capsaicin.
stopped that? I thought
No,
they stopped that.
still,
Uh,
yeah, the pharmacy will not get it, okay, but you can get it
mm,
over Amazon. Yeah,
mm,
yeah, I can. Usually I'm advising if I have something like that to bring it from Amazon, okay? Because capsaicin will cause irritation to the skin, and there is a significant link between
mm.
the receptors in the skin and the receptor in the brain. I will show you the diagram, okay? And specifically capsaicin, or heat, and that's why the hot showers is helping the people, and
Ah,
yeah. So
okay,
because
fine.
it's stimulating the receptor, yeah, that's the science behind it, okay?
Mm,
Sometimes you can use haloperidol, but I don't advise to use it in the primary care, okay? I used to use
mm,
the haloperidol with these patients as injection if they come with the acute symptoms in the emergency department. Okay, I don't advise. Okay, because tablet form will be very difficult, to be absorbed with the vomiting. This is one. But Ondansetron is good for even if the patient is vomiting, because the ondansetron is, if you told the patient to put the ondansetron under her tongue, or that will be absorbed.
mm.
Okay, because the transmucosal absorption is very, is too much for the ondansetron. Okay, it's like the sublingual nitrate. If you put it under the tongue, it will be absorbed. Exactly the ondansetron. If you put it under her tongue, it will be absorbed. So the transmucous absorption for the ondansetron is perfect. Okay, so even the patient if is vomiting, it will help. Okay. If you will do, haloperidol for any patient, just an advice, please don't prescribe haloperidol without doing an ECG
Antiemetic.
for the patient. No, no, no.
Okay.
Yeah, for sure, it can be as an antiemetic, or sometimes as mood stabilizer, or sometimes, especially, yeah, mood stabilizer or antipsychotic. Okay, without doing ECG, it's not good. Okay, because it can increase the QTC interval, and then that can cause, VTAC or VF for the patient. Okay, I will go rapidly through the PowerPoint. Okay. Do you have any question? And thank you very much for participating. And just don't forget the last 30 seconds of the case. You need to wrap up. Okay.
Mm,
Safety netting and follow up plan. Wrap up, safety netting and follow up plan. Okay.
mm.
Yeah, well done. Well done. You did reach 50% of the diagnosis. So I'm happy. No, no, that's good. No, that's good.
Okay.
At least you had to think about, cyclical vomiting syndrome.
Hmm.
And now you will never forget to ask about drug of misuse.
Recreational
Okay,
drugs.
yeah,
Yeah.
yeah,
Yeah.
drug of misuse. It's not a routine, but if there is a chance that the case presented in front of you can be related to the drug of misuse, yeah, you can. It's better to ask for sure. Okay.
Mm. Yep.
That's the background about the hyperemesis, cannabinoid hyperemesis syndrome, and you will have a long-term history of the syndrome itself. Okay, the patient will come with frequent tummy pain, nausea, and vomiting, and then it will be in cycle. What does it mean in cycle? Mean the patient will have the symptoms and then resolve, and then will have the symptoms again and resolve, and usually it's having three phases. So the prodrome, and then the vomiting, and then the recovery phase. And we'll see that in detail in the following slide. It was first introduced in 2004. Okay, and it's part of non-organic nausea and vomiting syndromes, which are three syndromes, which can be the chronic nausea and vomiting syndrome, okay, and the cyclical vomiting syndrome, and then the cannabinoid hyperemesis syndrome. Although cyclical vomiting syndrome is something you can meet, frequently in the practice, and then all of these syndromes are diagnosis of exclusion. So you need to exclude the pathological causes of the tummy pain and the chronic vomiting before, nominating the patient that they have non-organic nausea and vomiting syndromes. And then per se, for diagnosis of cannabinoid hyperemesis, there should be chronic use of cannabis, okay, at least 1 year. Chronic use of cannabis, not excessive use, and there is difference. It's a chronic use. It's related to chronicity because the cannabis will downgrade the centers, the receptors on the vomiting centers and then the GIT, and that is the main cause of the syndrome. So to downgrade these receptors, that need the chronic use, not the quantity, is the chronicity, the time of use. Okay. And again, it's come with episodic form, and then history of cannabinoid use, not excessive cannabinoids, and the washout period. And then these are the stages with the prodrome, is, the nausea and feeling tummy pain, and then the progressive vomiting, which is improved with the hot shower, and then the recovery phase. Yeah, that's just to a demonstration how the life of the patient is. And then these are the some of the symptoms that the patient can present with, and usually the presentation will be below 50 years old, and one of the complication of the syndrome that the patient will lose weight because he will be worried from eating. Okay, so this is the pathophysiology, as I said. So the cannabinoid, and the most active ingredient, or involved ingredient in such syndrome, is the tetrahydrocannabinoid, which is present on most of the over-the-counter cannabinoids preparation. Okay, so even if the patient taking cannabinoid, medical cannabis can present with that. And these are the receptors. So type 1, cannabinoid receptor, and the TRB receptor present in the intestine and the central vomiting center. Okay, and here you can see the receptors in the GI or in the brain. Okay, with the chronic use, they will be downgraded, downregulated, and the downregulation will make the vomiting to be induced. Like upregulation will prevent the vomiting from happening. And then the cross activation is happening by either the cannabis or by heat, and that's why hot showers improving the patient's symptoms, or by the capsaicin, okay, or the capsaicin substance in the hot pepper. Yeah, here from this slide, well, what I need to say that it's a diagnosis of exclusion, and also to try to exclude if the patient presenting in the acute phase, to try to exclude the complication, namely electrolyte disturbance, dehydration, and acute kidney injuries or hypoglycemia, because the patient will be, off food for at least a week or 5 days. Part of the differential, please, we said in the female, don't forget, gynecological causes, endometriosis, okay, as one of the differential, okay, and also diabetes, gastroparesis, okay. Management wise, withdrawal of the of the cannabis, okay, and giving in symptomatic treatment, okay, which is, as we said, either the ondansetron, which very good for such cases because it has the transmucosal absorption is high, promethazine, okay. In the old guidelines, this is old guidelines, okay. In the old guidelines, we used to give, benzodiazepines, but I advise against that because benzodiazepine will make the patient then, addicted to the benzos, okay. Then you are treating something and making and putting the patient in another problem, okay. The hot showers and the capsaicin cream and the haloperidol, and referring him to the the in the misuse drug misuse services. Okay, and this is what we said about haloperidol and what you should do. Attention is, the metabolic causes. Yeah, the question is if you have and this is also important question in your real life. If you have, male patient. So this was a female patient. We said with every female patient, please consider gynecological and endometriosis thing, and for sure the metabolic causes. But what about, when you have a male patient, okay, in his 50s, to 60s, and coming with frequent tummy pain, what you need to be aware about? Can anyone let me know?
Pancreatic cancer. Mm.
Well, that will be in female or male, but specifically in male, what you need to be aware about.
Prostate.
Cardiac causes.
Cardiac causes will be in male and female,
Prostate.
mostly. Metastasis, bone? Well, could be,
Yeah, prostate medicine.
yeah, but no. I mean, not everyone will come with tummy pain. You need to think about prostate because if he doesn't have
Right.
lots of symptoms, you
Abdominal
will.
aortic aneurysm.
Yes, who
Triple A.
answered this? Yeah, triple A? Who answered? There's two doctors answered. Who answered it?
نصيبة.
Nusaiba and the other doctor,
مختار. Islam.
Islam. Okay, Islam and
Yeah.
Mukhtar. Okay, okay, okay. Yeah, please. Triple A is one of the important differential, please. Okay, one of the important differential in any patient coming for you, especially male patient in their 50s and 60s, coming with a tummy pain, abdominal pain, or even renal colic, okay, or back pain. Okay, don't forget to just put the stethoscope in his abdomen and try to listen to any murmur. Okay. Um, Believe me, if you try to do that, you will discover a lot of things. Okay, you will find a lot of abdominal aortic aneurysm that you can only diagnose it with just listening to the to the abdomen of the patient. Okay, listen to the abdomen. Okay, it's an important thing in your examination that you need to listen to the abdomen of the patient. Okay, because usually if the triple A causing tummy pain, that's mean he is big enough to cause compression symptoms. Okay, that's mean most probably if you put your stethoscope in the tummy of the patient, you will listen. You will listen to something. Okay, you will listen to a murmur. Um, I had a lot of patients that when I was working in the emergency department that was misdiagnosed in the GP land, with renal colic and UTIs, and actually they are coming with triple A. and abdominal pain. So not every abdominal pain or renal colic is UTI, or not every renal colic is, is ureteric stone. So just be mindful of it, okay? Don't be obsessive of it. Be mindful of it, because unfortunately you don't have bedside ultrasound in the GP. Otherwise, I would advise you, every patient will come with a tummy pain, just put a probe, bedside at his tummy, and see if there's any abnormality there. Okay. Um, mm, yeah. So yeah, this is just a differential here to differentiate between the hyperemesis gravidarum and the cannabinoid hyperemesis syndrome. Okay, because they can be mixed. Okay, and the complication more or less same. Um, the other thing, as I said, a child with abdominal migraine, don't forget to ask if the patient, if the parents are smoking cannabis, because he can have hyperemesis, cannabinoid hyperemesis, and actually not an abdominal migraine. Okay. Uh, well, I nearly finished. I'm more than happy to get any questions. Okay, if there anyone have question, I'm more than happy. No, all are satisfied. No one have question for, any question and any guidelines. No. Okay, so I will conclude. Be aware, please, that about the WhatsApp group, and and the YouTube channel. Okay, and please, if you need any help or support, I'm more than happy to help you and support you. I have been, away for, from the weekly teaching, during maybe the last month, but we will start to every Wednesday to have the regular teaching, and I'm more than happy to see you all every week. Okay. Please, if anyone have any question, I will just stay for a couple of minutes. So, and then I will just end the meeting. So if anyone have any question, I'm happy to receive it.